broadcasting.
لما تحبين ابتدي يقول لي.
Okay, broadcasting. We are on now.
Good afternoon, ladies and gentlemen. Today, this is our fourth webinar in the series that we are organizing between the Egyptian Society of Colon and Rectal Surgeons and the Egyptian Society of Laparoscopic Surgery, with the full support from Medtronic company. So this is the fourth webinar, and as I usually tell each time, the meeting is recorded, and you can ask for CME credit certificate after attending the 4 webinars. We will send you an email to ask you if you want a certificate for attendance and the certificate for the credit hours or not. And if you want, please reply to our email so that we can send it to you. I welcome Professor Hassan Shaker, Professor of Surgery of Ain Shams University and the Secretary General of the Egyptian Society of Laparoscopic Surgery. And I will ask him to introduce this webinar. Professor Hassan Shaker, you have the microphone. Thank you.
Thank you, Professor Khaled Madbouli. He's the stakeholder of this activity, which has been active. This is for the fourth lecture today. Professor Khaled Madbouli is the head of the Egyptian Society of Colon and Rectal Surgery. And as he said, this activity in collaboration with the Egyptian Society of Laparoscopic Surgery. One of the eminent figures of the Egyptian Society of Laparoscopic Surgery from its start is Professor Dr. Ahmed Shukri. He is consultant of surgical oncology and laparoscopic surgery at the Salam Oncology Center, and he is the chairman of the surgical department in the Salam Oncology Center. He has a very eminent and very highlighted profile in the field of laparoscopic surgery, not in the colorectal domain only, but in the rest of the GIT. And today he will give us a lecture which I believe would be so interesting, because he will speak about the management of the ultra-low rectal cancer. Professor Ahmed Shukri will start now. Tfadal, Dr. Ahmed.
Thank you very much, Professor Hassan Shaker and Professor Khaled Madbouli for your nice introduction. And I thank Medtronic for supporting the educational activities in these difficult times. And I thank the Egyptian Society of Surgeons and the Colorectal Society of Egypt for hosting and for sponsoring these educational activities. Our topic today will be on the management of ultra-low rectal cancer. Ultra-low rectal cancer is a very big problem that is difficult to manage for everybody. And it presents a real challenge both for the surgeon and for the patient, of course. And you will be amazed that in 1903, the review by Charles Mayo in 1903, which is more than 110 years ago, termed evolution in the treatment of cancer of the rectum. I will quote exactly the words that he said.
السكرين بتاع حضرتك ممكن شير السكرين بتاع حضرتك.
ايه ده؟
شير سكرين.
هو كل ده السكرين مش شير؟
Yes.
Okay. Sorry for that. Now you see the screen?
Yes, yes, that's fine. Good.
All right. So
كده تمام يا دكتور احمد اتفضل.
all right. As we said, in 1903, Charles Mayo published a review on the evolution in the treatment of cancer of the rectum. And he stated the following: certain definite results are desired in operations of the rectum, namely permanent cure, low operative mortality, and a controllable anus or its best substitute. And these results are modified by the location, the stage of progress, and the age and the condition of the patient. Unquote. This was 110 years ago. And through these lines, we still are managing rectal cancer, despite our major advances in radiology, in surgery, in pathology, in medical oncology. We still have a problem managing low rectal cancer. And of course, one of the major devastating events is the permanent colostomy and the problem of the tumor control itself. And I would like to emphasize a very important notion that I keep telling everybody who is operating on the rectal cancer and in oncology in general. It is not what you have removed. It is what you have left behind. So don't get excited that you have removed a specimen, but you should be very proud that you have left the patient with an R0 resection. So don't focus on what you have removed, focus on what you have left behind. And we don't want you to leave anything behind, of course. If we step a little bit in time backwards, like 25, 30 years ago, the results of management of rectal cancer was extremely poor. It was like 30 to 40% local recurrence rate, less than 40% survival. And this was really very poor results. Until these two gentlemen came aboard, Bill Held and Philip Kirky, a pathologist and a surgeon who joined hand in hand to try to figure out what is the problem with the rectal cancer surgery. And they came up with a very novel and a new concept. If you have a positive circumferential resection margin, your survival dips down by half. You cut your survival by 50% if you have a positive circumferential resection margin. And the concept of circumferential resection margin was not there. They invented it because everybody was keen and very focused on the lower resection margin. How many centimeters from the lower edge of the tumor we need to go. And they used to remove 4 and 5 or more, and it did not improve local recurrence, it did not improve survival. So when Bill Held and Phil Kirky came up with the circumferential resection margin concept, which later on evolved into what we call now the TME. You see that in this picture, the rectum, the tubular muscular rectum is a minority within the facial envelope of the fascia propria of the rectum, which is surrounded by the mesorectal fat, which is carrying all the lymphatics and the lymph nodes surrounding the rectum. And this is what we term the circumferential resection positivity or negativity. So we need to focus on the mesorectal excision, not on the rectal excision. And this is totally different concept, which they came up with. If you see in this picture, the tube, the muscular tube of the rectum is within an enclosure of fat and lymphatics and lymph nodes, and everything is invested in one complete layer of fascia, which is the mesorectal fascia, which is the fascia propria of the rectum. And you need to remove this package, one package. And if you see here, in this picture, in the lower part of the screen, this is the different cuts in the different levels of the rectum. You will have parts of the rectum with a peritoneal covering, and you will have parts of the rectum without peritoneal covering. And those without peritoneal covering, you have to remove them within the enclosure of the endopelvic fascia, of the rectal fascia, the perirectal fascia, the fascia propria of the rectum. And you see the muscular tube, which is yellow with the T, the tumor is there, and the distance from the tumor to the peripheral margin, this is what constitutes the circumferential resection margin that they talk about. So the first step in the evolution of rectal cancer management was the development of the concept of the total mesorectal excision. And this have been reflected on the way we process the pathology. You cut the specimen in an axial way so that you can judge where the tumor goes to the closest area of the peripheral circumferential resection margin. So even the processing of the pathology has changed over time due to the concept of the total mesorectal excision. Two very important notions came out of the concept of the total mesorectal excision, which is that surgery for tumor, for cancer, you need to go along embryological planes. You as a surgeon, your job is to unfuse the embryological fusion planes that happened earlier on during development. If you go along these embryological planes, you will keep the facial coverings intact so that your radicality will be very clear. The second notion is that you need to remove the rectum with its mesorectal covering and fascia as one package, an intact package. You do not want to violate the fascia, because if you violate the fascia, you will leak lymph, cells will trickle from the mesorectum to the surrounding tissues, so you can implant malignant cells in the pelvis if you breach the mesorectal fascia. So these are two very important concepts. Again, it is not what you have removed, it is what you have left behind. The second step in the evolution of the rectal cancer management was the development of laparoscopy, of course. And in a very recent review and meta-analysis of a comparative study between open and laparoscopic rectal cancer surgery, it was published in 2018. The final word was that there is no statistical difference between open and laparoscopic surgery for rectal cancer, as results show. So if you use laparoscopy in a wise and a good judgment sense, you can add to the surgery that you perform for rectal cancer. Another point where evolution of rectal cancer management has a great impact is the use of radiotherapy. And traditionally, radiotherapy was given to the patient post-operative. And this was not the best thing to do. It has been shown that the pre-operative radiotherapy, while the organs are in place, fully vascularized, fully oxygenated, this has a much better impact of the radiotherapy management on the tumor cells, much better than the post-operative radiotherapy in an ischemic fibrotic field. So pre-operative radiotherapy is a major advancement that happened in the process of the management of rectal cancer. And there are many ways to give radiotherapy. We are going to touch on that. And there are different techniques and different linear accelerators, and you can use intensity modulated radiation or the 3D conformal radiotherapy. So really a great deal has been achieved in the area of radiotherapy, and this has helped surgeons very much in controlling the disease while performing the surgery. So the three key steps in evolution of the management of cancer of the rectum were TME, the introduction of laparoscopy, and the use of radiotherapy in pre-operative setting. So this discussion was just for any kind of rectal tumor. All rectal tumors need to have a TME, or rectal tumors can be approached by laparoscopy, and when indicated, they should receive radiotherapy. What about our topic today, the ultra-low rectal? This is the most difficult of the most difficult. If rectal cancer is a very difficult disease to treat, the lower you go, the more difficult it is. The more difficult it is because of technicalities, the more difficult it is due to tumor behavior and incidence of recurrence, and due to anatomical constraints, due to the structure of the pelvis and intimate, important visceral structures like the prostate, seminal vesicles, the neurovascular bundles, the urogenital innervation. So what about the ultra-low rectal cancer? How can we approach these lesions in 2020? Abdominal perineal resection was the standard of care and still is the standard of care against which we can compare any other mode of management of rectal cancer, 5 centimeters or less from the anal verge, that it is not amenable to local excision. If you have a T1 lesion, which is very rare to meet, you can treat it by local excision, but we usually, the bulk of the patients are T3 or more. So APR was the standard of care, and still it is the point of comparison against which we should compare any new treatment, because this is the most successful way to control local regional recurrences. But if you choose opt for APR, you will have a patient with a permanent colostomy and with the added sexual and urinary dysfunction, which is really not the best quality of life. So, as we said, we have evolved techniques and concepts in the management of rectal cancer, the TME, the radiotherapy usage, and the laparoscopic approach. So by integrating these together and by creating what is now a necessity in every department managing rectal cancer, what we call the multidisciplinary approach, the MDT team, with the use of the preoperative concomitant chemo radiotherapy. The aim is to downstage the lesion for better local regional control and for better and easier surgery. The use of laparoscopy, as we said, it has allowed us to visualize the pelvic floor muscle from the abdominal cavity like never before. We can dissect, evaluate, and preserve the sphincter complex by the use of laparoscopy, because we can see the sphincter complex itself, we can see the levator ani, we can go into the intersphincteric space and evaluate it and see if the patient needs an APR or not. So by integrating laparoscopy and the multidisciplinary approach in management, this has allowed us to do much greater percentage of patients in a sphincter preserving way in properly selected patients. And to tell you that the problem is of a big magnitude, in 2011, in the United States, they made the ostrich system. The ostrich system is short for optimizing the surgical treatment of rectal cancer. We are talking about the United States of America. We are talking about the leading country in the world, and they have a big problem, and they have a big problem managing rectal cancer. They have it because there is existing disparities in the US among centers and among hospitals treating rectal cancer care. They found that there is a very big percentage of patients having abdominal perineal resections, while if they were treated in Europe, they would not get an APR. And the difference inside the United States from center to center, from state to state, was very big. So they needed to unify their protocols and to have guidelines to mandate a different form of approach to rectal cancer in the United States. And this was just in 2011. We are not talking about 40 years ago. So the current evidence in support of the adoption of 5 main principles treatment in rectal cancer. Of course, we said the TME, this is the major step in the management of rectal cancer, no matter what level we are talking about. The specific techniques in pathology assessment, this is very important. You must get a feedback from the pathology telling you if you are doing a good job or not. The pathologist is not there to tell you that the tumor is a T2 or a T3 and 1 and that's it. No, the pathologist must qualify the specimen that he gets. He must tell you that you did a good TME or you did a suboptimal TME or you breached the fascia or you breached the rectum itself. So there is a qualitative assessment of the pathology specimen. Imaging techniques is very important. We are going to touch on that very quickly. The use of neoadjuvant treatment, which is now mandatory in almost all cases, and the development of an MDT approach and a multidisciplinary team for assessment of every patient in a very specific way. Imaging. We can do endorectal ultrasonography, we can do CTs, MRIs, PET scans, and PET CTs. And the imaging is twofold. We can do it the pre-neoadjuvant treatment and the post-neoadjuvant treatment. This is a table for the advantages and disadvantages of each, but the very important thing for us is the MRI. And when you order an MRI for rectal cancer, please order an MRI with rectal staging protocol, not the pelvic MRI, because these are different. MRI of the pelvis is not a rectal staging MRI. So you need to order a rectal staging MRI. And the MRI is the best option nowadays for staging and decision management in rectal cancer, especially in low rectal cancer. And it is the best modality to assess the response to neoadjuvant treatment. If you have an endolectal ultrasound, it can help you in the pre-neoadjuvant assessment, but it will not be of any use in the stage of post-neoadjuvant treatment. Post-neoadjuvant, the best thing is the MRI. And in MRI of low rectal cancer, we can assess if the tumor is involving the full thickness of the rectum or not, if it invades the intersphincteric plane or not, if it invades the levator or the external inner sphincters or not. This is very important. And there is a grading system for the response to neoadjuvant treatment. If there is a good response, which is grade 1, if there is absolutely no response, which is grade 5 and all the degrees in between. And the MRI can visualize the peritoneal reflection, which are here marked in yellow, the presacral fascia, which is marked in green, and the mesorectal fascia, which is marked in red. So you can see the tumor and the distance from the mesorectal fascia and distance from the inner verge. The best way to know exactly the distance between the lower end of the lesion and the inner verge is the MRI. Never, never, ever count on the endoscopy count. Never. The best modality is the MRI. And even the seminal vesicles and neurovascular margin, neurovascular bundle involvement can be visualized in the MRI. And here you can compare the pre-operative to the post-operative after pre-neoadjuvant and after neoadjuvant treatment. On the left, the pre-neoadjuvant, and on the right, the post-neoadjuvant, with a very sluggish response here, but with a good response in this case between the upper right side picture and the lower right side picture. The lymph nodes in the mesorectum has been considerably downstaged by the neoadjuvant therapy. And in advanced loco-regionally cases, and you have here venous infiltration by the tumor, and you have very ugly lymph nodes with along the internal iliac vessels, very obvious in the MRI. So MRI is a very important modality in management of rectal cancer. And here you can see in this, in the left side picture, you can see the levator muscle with the orange arrows. You can see the wall of the rectum, yellow arrows. The purple line and arrow, the intersphincteric plane down to the anal canal. the external anal sphincter, the red arrow. So you can really judge with a very big percentage of certainty which kind of surgery you are going to be performing for this patient after the neoadjuvant treatment. In an attempt to classify and standardize the surgery, Eric Roulier has proposed 4 types of low rectal cancer. Type 1 is the supraanal, type 2 the juxtaanal, type 3 the intraanal, and type 4 is the transanal. And as you see here, if you have more than 1 centimeter below the edge of the tumor and the anorectal ring, this is the supraanal. If you have less than 1 centimeter, this is the juxtaanal. The lesion is invading the internal anal sphincter, it is intraanal. If it is invading the external anal sphincter, it is transanal lesion. And depending on which tumor you have, the plan of radiotherapy and the plan of surgery can be made. And he suggests in type 1, by the way, the 2, we are going to touch now on the 2 modalities of radiotherapy that we have. We have the short course radiotherapy, which is you give the neoadjuvant radiotherapy in 5 days, 5 fractions, in a total of 2,500 centigrade. And you have the long course radiotherapy, which is over 5 weeks, not 5 days, 5 weeks, and a total of 4,500 centigrades. The difference between the 2 radiotherapy regimens is that the short course does not allow for tumor shrinkage or downstage. The cells of the tumor are hit by radiotherapy. They are extensively damaged by the radiotherapy, but the tumor is still there as a gross anatomy. It is still there with the same size, with the same extent. So if you need to downstage the lesion, because this might change your decision in the type of surgery that you are going to make, you need to give the patient the long course, because the long course gives time for the tumor to shrink, for the radiotherapy effect to be visualized, to be emphasized on the gross morphology of the tumor. So if you have a type 1 or a type 4 lesion, a patient who will be easily done with a low anterior resection, or a patient who is definitely for abdominal perineal resection, I personally opt for a short course radiotherapy. But lesion type 2 and 3, which is the patient has a 50-50 chance of having a sphincter saving surgery versus an abdominal perineal resection. These are the lesions best treated with the long course, because you need the tumor to shrink so that you can evaluate the patient better. Maybe you can give the patient an intersphincteric resection instead of APR. Maybe you can do an anterior section instead of an intersphincteric resection. So this is the classification of Eric Roulier and how this is reflected on the choice of the surgery and the choice of radiotherapy management. And this is the same anatomy, but here we want to emphasize that on the type A resection along the yellow line, if this is an extra elevator APR, and you see the lesion is just inside the luminal wall. It is not outside. So this is a grave over treatment of condition A. And on the right-hand side, the condition B, the green line is the intersphincteric surgery line. And the tumor is going to the levator line. So this is a gross undertreatment. So you really need to know where the tumor is, where your spaces are, where the muscles are, to make a good judgment on where to operate and to end up with an R0 resection. Remember, we said it is not what you have removed, it is what you have left behind. So now if I have a patient with a low rectal cancer, how can I approach the patient? We usually do a multi-slice CT scan, chest, abdomen, and pelvis. We do an MRI rectal staging protocol. I like to do an examination under anesthesia for all patients for better assessment of the lesion. And then, based on the MRI and the EUA, I decide on the radiotherapy protocol, if we are going to use the long radiotherapy protocol, 5 weeks, or the short protocol, 5 days. If we use the long course protocol, the 5 weeks, we give the patient 8 weeks rest and then do the repeat MRI. If we don't use the long course, we go straight for surgery after the radiotherapy within 3-4 days of ending the radiotherapy, because there is no sense repeating the MRI because nothing has changed. The morphology, the gross picture of the tumor is still the same. The tumor cells are irradiated, but the tumor is still the same. So if we go for a long course, we give the patient 8 weeks rest and then do the repeat MRI. And then we go for laparoscopic intersphincteric resection at 8 to 10 weeks and a loop ileostomy. If the patient needs to get chemotherapy, we refer the patient to chemotherapy. And then before closure of the ileostomy, we send the patient for physiotherapy or electrical stimulation and biofeedback training to strengthen the sphincter muscles before closure of the ileostomy to aid the patient in better control and continence. So this is the flow chart of managing how to manage the low rectal cancer patients. And this is the picture of the intersphincteric space. This is after we finished an intersphincteric resection and we have delivered the rectum to the outside, and this is an abdominal view of the sphincter itself, the levator and the puborectalis, and this the gauze is in the intersphincteric space. So this is where the colon will go through and then do a coloanal anastomosis. So this is just to give you an idea about what we are talking about and where is exactly the intersphincteric space. Okay, now we have a video to show. I have omitted the abdominal part, and we are going straight to the pelvic part of the resection. And as you see here, this is the holy plane of Bill Hill. You have anteriorly the mesorectal fascia, and you see a lymph node protruding inside the mesorectal fascia. And you have posteriorly the presacral fascia. This is a female, and what you see here is the hypogastric nerve. I like to use monopolar energy in the pelvic dissection because it is very helpful in delineating the planes. Energy devices, whether bipolar devices or ultrasonic devices, they tend to fuse the planes. So it is better to use monopolar energy because it is a better delineation for the plane. And you are carrying the dissection downward. We started, as you have seen, posteriorly, sorry, and then you carry it laterally and then anterior. And now we are dissecting the vagina from the anterior wall of the rectum. And because we are going to do an intersphincteric resection, so you need to go very deep in the pelvis. So you walk yourself a little bit posterior until you get to the elevator, and then you go lateral, and then you go anterior, and then repeat the sequence if there's still areas that needs to be dissected. And now the levator fibers starting to show, and we are approaching the intersphincteric space. This is where the scissor is going. This is the intersphincteric space. So now we are evaluating exactly the tumor and the intersphincteric space. And you should do, when you reach the intersphincteric space, a digital palpation of the rectum to assess the lesion and to assess the intersphincteric space. And as you see here, we are pulling on the rectum so that now the level of the anal canal is actually in view. And this is the anal canal area where it is going through the muscle. And you see here the muscle of the pelvis, and the anal canal is going through this, the elevator hiatus to the end. And the remaining attachment of the vagina with the rectum and anal canal is dissected. So now we have done the total mesorectal excision, and we have reached the area, and you see the contraction of the elevator when we activate the energy. So this means that you are on the level of the muscle. And this is the muscle here. This is the intersphincteric space very clearly. And now we are going to do the PR and the digital palpation of the lesion and to know exactly where we are. And actually, we can palpate the tip of the scissor from outside. And this is the view that you have seen before. Goes inside the intersphincteric space, and the contraction of the muscles. And now we are going to deliver the colon. And of course, you need to do a very good splenic flexion mobilization for the colon to come down without any tension. So now the colon is going through the intersphincteric space, and we are going to do the anastomosis, coloanal anastomosis. One very important issue here, especially in the intersphincteric resection, is that the way the colon is going into the pelvis. Okay, you see here the S-shaped redundancy of the colon. This is very, very, very important in intersphincteric resection or all low rectal resection. If you do not have this sagging colon inside the sacral concavity, so that the colon is going downwards and then upwards again to reach the levator hiatus and the anal area. If the colon is going straight downward, like a string, this patient for sure will be incontinent. because the contraction wave of the colon will not be dissipated along different directions. The contraction will be immediately upon the sphincters themselves, and it becomes very difficult for the patient to hold himself or herself. And this is where the colon is going through the intersphincteric space. This is the elevator, and the anastomosis outside. This is another case. This is a male, which is more challenging and more demanding. And we have, because we did not know exactly what we are going to do, so we did not do any abdominal dissection yet. We started the pelvic dissection first because we wanted to know exactly if we are going to do an APR or we are going to do an intersphincteric resection. So if we are going to do an APR, there is no need for splenic flexion mobilization and wasting time during the surgery. So we started up front to do the pelvic dissection. And this is a different way to do it. So you will work yourself in a much more constrained anatomy. But if you are familiar with the procedure and with dissection of the pelvis, it's not a problem. It's very important to take your time and be very slow in development of the plane. This is very important. And now you can see the mesorectal fascia and the two halves of the mesorectum starting to develop. And this is the plane between the mesorectal fascia and the presacral fascia. And what you see here is the nerves, the sacral nerves, starting to show. And this is the loose areolar tissue between the mesorectum and the presacral fascia. So you can work yourself. You see here the two lobes of the mesorectum. And by increasing the traction and the counter traction, what you see here is exactly the nerve, one of the sacral plexus nerves going along the facial cover. You need to be very careful, and this is the nerve on the opposite side. So you need to really be in between the two layers of fascia. And always remember, when you are going from posterior to lateral, that the mesorectum is a cylinder. It curves laterally. So you need to curve with it. You do, one of the big mistakes when you are going from posterior to lateral, you tend to go transversely. And this is very dangerous because if you go transversely, you can injure the nerves, and more importantly, you can injure the internal iliac vein. So you need to curve yourself with the curvature of the mesorectum. And you see here the nerves going along the side wall of the pelvis, and you are working yourself between the two layers of the fascia, always in the loose areolar tissue. And you are trying to preserve the mesorectal fascia and preserve the presacral fascia, because the presacral fascia is the safety against nerve injuries and vascular injury, and the mesorectal fascia is your holy plate. So you need to be always between the two layers of fascia. And you go deeply, bit by bit, and mainly posterior. Mainly posterior. Go posteriorly as deep as possible, because this will give you perspective on how the anatomy of the pelvis is like, and it will help you in the remaining part of the surgery. And after we dissect posteriorly, until the deepest point, we start to do the lateral dissection bit by bit. And if you don't have proper traction, you need to change the way you are retracting until you get a very clear view on the retract. Of course, we use only 30 degrees lenses, because you cannot use a 0-degree lens in such surgery. And you need a very good camera person, because this is a very confined space. And remember, we did not dissect abdominally at all. We are only working in the pelvis. And you see now the sacral nerves along the lateral pelvic wall. Now we are reaching the bottom part of the pelvis near the elevator. So the dissection is carrying on, and this is the side wall of the pelvis, and you can see the sacral nerve. And you are opening the plane, then carrying the section down. Anteriorly, in the males, it is better to open up a little bit higher than usual. On the top of the seminal vesicle, to have a flap to raise so that you get into the proper plane easily. So what we see now is the seminal vesicle anteriorly, and we are carrying on the dissection anteriorly. This is the vase. And you dissect until you reach the fascia of the non-VDA, which is a very important landmark. Here, a word of caution: when you pull on the rectum toward your side, you are pulling with it all the lateral structure that should be on the lateral pelvic wall. So this is the nerve. You see the nerves, sacral nerve, the neurovascular bundle, going along around the tip of the seminal vesicle to supply the genitourinary organ. So you really need to push them to the lateral pelvic wall all the time, and take into account the fact that you are pulling up the rectum towards you, bring them towards you a little bit. So you need to clarify the anatomy. These are the nerves right here. They are going, you see, when you pull, you exert traction on them, and then you bring them more medial. So if you are not taking care of the dissection plane, you can injure these nerves. So you need to be careful on how to release them and let them go back to the lateral pelvic wall. This is what we are doing now. We just very judicious use of diathermy, very, very minimal use of diathermy, and then opening the plane and pushing towards the lateral pelvic wall so that you clear them away from your feet. This is very important. And you see, the seminal vesicle is going higher and higher every time you release and push. And now what you have is the non-VDS fascia on the anterior wall of the leg. Whether you go anterior or posterior to the non-VDS fascia, it depends on the location of the tumor. And if you have a posterior lesion, it's different than you have an anterior lesion. If you have an anterior lesion, you want to take part of the fascia as a protective layer with you. And now we are carrying the same dissection of the seminal vesicles on the right side. And the key point is the traction and the counter traction. You need to retract the seminal vesicles upwards and retract the rectum backwards, not upwards, backwards. This is very important. And this is the non-VDS fascia here. now we have opened the non-ombilical fascia. And once it is open, it is very easy afterward to release the seminal vesicles completely. As you see here, it gets detached and it is going upwards. And you can start to see the fat of the mesorectum anterior. Traction and counter-traction, this is very important. Now the assistant is raising the seminal vesicles, as you see. And now I'm retracting with my left hand downwards. This is very important. So now I'm opening the space and carrying the dissection. If you have smoke, you really need to be patient until it clears away. Don't work while you cannot see. Because laparoscopy, we only have visual guidance, so you need to see all the time. You just be patient and wait a few seconds before you can activate your energy again. See, traction is very important to open up the plane. And it is totally different than the female pelvis that we have seen in the previous video. Here we have a lot of dissection to do with the seminal vesicles, and if you want to be really nerve sparing, this is very important and it needs very accurate dissection. You see here the nerves going along the lateral aspect and at the tip of the seminal vesicle. This is so your dissection is on the inside. If you dissect a little bit lateral, you will injure the nerves. So this is a very important area, and developing anterior dissection and posterior dissection makes it easier in the area of the tip of the seminal vesicles, where exactly the neurovascular bundle is running. It is very important here to see very well from above. And you see here one nerve, another nerve, a third nerve, and these the sacral nerves that are going to constitute the nervi irrigentis later on to supply the genitourinary system. Now you have reached the vagal space, and now this is the edge of the intersphincteric space. So you have reached above the nerve and secured the nerves and reached all the way to the bottom. This is the seminal vesicle. The tip of the seminal vesicle is here, and the nerves are going this way. So now you can go across safely in the proper plane. And again, your cameraman or woman needs to be very active and get you to see where you are exactly, because if you lose your orientation, this is a very important area with a lot of important structures. So it is really a difficult job for you and a difficult job for your camera person. But this is what we have been talking about, the fact that how surgery of rectal cancer has evolved. When we said that TME was a revolutionary concept, and laparoscopy also is a revolutionary concept, because now you can still you can see now the nerves under magnification, and you can see the pelvic floor. You are carrying your dissection bit by bit until you reach the intersphincteric space. Now, the complete release of the seminal vesicles and the lateral structures to reach the intersphincteric space. This is the intersphincteric space right here, and now you see the muscle bundle, and the intersphincteric space is right there. This is the white arc that denotes the end of the mesorectal, dissection. Because after that, that will be the levator hiatus. This is the white arc right here, and this is the intersphincteric space that I went just in. Okay, so this is exactly what you want to be, and this is how laparoscopy give you a very beautiful view, a very beautiful evaluation of the intersphincteric space. You can do a digital rectal examination now, so you can see where your finger is, where the lesion is, where the muscle is. And you can have an excellent judgment on the possibility or not of preservation of the sphincters and avoiding to do. And this is what we're doing. We are assessing the lesion digitally under vision of the laparoscopy. So this is the essence of the laparoscopic approach. Okay, we are going to move things a little bit due to the constraint of time. We are going into the intersphincteric space and bluntly opening it up with the grasper, as you see, to have a space to push a gauze inside the intersphincteric space, because I like to do that and then get the gauze from the transanal surgery part, so that you know where your space is. It's much easier to know if you have a gauze in the space. You open up the mucosa of the anal canal on the gauze, and then you are in the intersphincteric space. This is the remaining dissection bacterial. And again, you need to be patient until smoke clears up, and then you carry on your work. This is the gauze that I'm putting in the intersphincteric space, and then I will open up the mucosa of the anal canal on this gauze, on the bulge of the gauze, and then pull the gauze outside, and then my finger will be in the intersphincteric space. Okay. One interesting point, this is the whole mesorectum, you see the whole mesorectum, and now the levator completely in view. What we are going to do now is the ICG. We are going to use the ICG to, you see the vessel, vascularizing vessel, the shining blue light, and which are checking the vascularity of the colon, and this is the area devascularized. This is where we are going to cut the colon that will go outside of the anus when we deliver the colon through the anus. So we have a good vascularity in the area that will be anastomosed. This is a very nice tool. If you have it, ICG is very nice. It gives you a great degree of comfort and certainty that you are well vascularized. This is the protruding colon through the anus after we have finished the anal part. And we are going to inject again ICG, and you see the colon that is through the anus, the transanal colon, is very well vascularized. It is bleeding blue, actually. So you are sure of a very good vascularity of the part of the anastomosis. This is what we do when we deliver the rectum outside, and then after the anastomosis. This is in the follow-up when the patient is contracting and relaxing the sphincter. And these are the specimens that we extract. So, because of the fact that you are doing an intrasphincteric resection does not mean you are doing less surgery. We said that we have to qualify the specimens that we remove, that we have to have good oncological results, intact mesorectal fascia, to have good margin, and this is the patient after the surgery with the ileostomy, after closure of the ileostomy. And finally, our dream, all of us colorectal surgeons, are to avoid completely 100% to do a permanent colostomy in all patients while we are controlling the tumor in a good manner. I know that until today we did not achieve this goal, but I think we are taking many steps closer to this goal, and maybe it is closer than we think it is. Thank you very much. If you want to see the full length of the videos that I have shown, they will be on my page on Facebook and YouTube. You can go and watch them anytime. Thank you very much.
ممدوح.
We have
Yes.
with us Dr. Mohammed Mamdouh. He's assistant professor of surgery at Al-Azhar University. He will be moderating the questions part and the discussion part. If you have any questions or you would like to discuss anything, please write your questions, and he will be moderating the whole thing.
Thank you, Professor Shokri, for allowing this chance for me to be a moderator in this great, informative, and instructive lecture. It's our pleasure usually to be with you among all your audience and colleagues. And on behalf of all your audience or your trainees, your students, myself one of them, thank you, and allow me to discuss all the questions came from the audience during the lecture. So many questions have technical issues, and as one of your students, I suggest that all those questions usually should come to your center and watch you. And the more you see surgery with you, the more you get oriented, and the more you get experience to learn through this surgery and learn from your experience, Professor. So a lot of questions came about the iliac lymphadenectomy during ultra-rectal cancers. So allow us to introduce those questions. Many surgeons ask about the lateral lymphadenectomy during rectal surgery, and when to do and when not to do those lateral pelvic lymphadenectomy. Please, Professor.
Yeah, this is a very good question. Any lymph node more than 5 millimeters in the MRI should be removed. So the MRI is the cut-off judgment for us if we are going to do pelvic lymph node dissection or not. If you have any lymph nodes that are 5 millimeters or more, they should be removed by lymphadenectomy together with the whatever procedure you are going to do, whether anterior resection, intersphincteric, or APR. This is very important. I did many cases. They were positive nodes, and the patients, they did very well after removal of the nodes, because if they are not removed, you would not have achieved an R0 dissection. So you really need to have the technical abilities to perform pelvic lymphadenectomy in cases of cancer rectum, especially if you have MRI evidence that you have nodes more than 5 millimeters in size.
Do you recommend the PET scan, sir, for confirmation about the positivity of those nodes?
I think there is a big issue, big problem in Egypt regarding PET scan. PET scan is abused. It is overused with in a tremendous way. Our dear colleagues in oncology, they are using PET scan instead of chest X-ray. And everywhere else in the world, PET scan is a very restricted investigation. So a good MRI is indispensable in rectal cancer surgery.
Yes.
I would never decide to remove or not to remove based on PET scan. I have seen many fallacies in PET scan, whether positive or negative. It gets confused. It depends where you do it, who is reading the scan, a lot of variables. But MRI is really indispensable as a modality of planning your surgery. I do not plan my surgery based on PET scan.
Yes, sir. Okay. Second question, it's a very good one actually. You mentioned about the examination under anesthesia to make for decision making together with the MRI scans. So many surgeons ask through the audience during the lecture about what to do and what to find, what to decide, how to decide the optimal surgery required for low rectal cancer through the examination under anesthesia.
Okay. Examination under anesthesia gives you a lot of information. First of all, it gives you a good idea about the location of the lesion from the anal verge, how many of the circumference involvement there is, mobility, and most importantly for me is the character of the lesion. The character of the lesion is a very decisive element in which procedures to do. If you have a deeply infiltrative lesion and a deep ulcer, I would be extremely cautious doing any conservative surgery on such a patient. These lesions, the deep ulcerating lesions, they need to be treated by APR. If you have a bulky lesion that is more protruding into the lumen, these are the easiest. The bigger the lesion, the more I'm happy. Because the tumor, when the tumor consumes its energy growing into the lumen, it's usually a very friendly tumor that is very amenable to surgery. The deeply penetrating tumor that are trying all the time to go out of the lumen are the nastiest tumors to treat. So examination is important to know the character of the lesion, to assess the character of the lesion in relation to the sphincters. When you put your finger and hold the sphincter in your hand between the two, the thumb and index finger, and you assess the tumor and the lesion, especially in females, because anteriorly located lesions in the females, if you are in need to resect posterior vaginal wall, makes things very complicated if you want to preserve the sphincters. So a digital rectal exam is mandatory, and EUA is mandatory. It gives you a lot of information, and I personally base my decision on short course or long course radiotherapy depending mainly on the EUA, aided by the MRI, but mainly on the EUA.
Okay, sir. Another question. Dr. Muhammad suggests that with the poor outcome of coloanal anastomosis, the functional outcome, I mean, why we still doing this coloanal anastomosis? So in other words, they are asking about your experience in the functional outcome after those intersphincteric resections, especially after physiotherapy. So what do you think, sir?
Well, it's a good question. And actually, there is a lot of details that we can talk about regarding these issues. Not everyone who can have an intersphincteric resection and a coloanal anastomosis should have one.
Yes.
I mean that there are patients who are oncologically fit to have an intersphincteric resection and a coloanal anastomosis, but I would still not do it. I would do an APR. For example, a patient who's 75 years old. This patient, if you do measurements of the tone of the sphincters, of the pressure, the inorectal manometry and everything, you will find that this patient is very close to being incontinent without surgery. This is his baseline due to aging and weakness of the muscle. So I would never do an intersphincteric resection and coloanal anastomosis to such a patient. You need to be very wise. I stopped completely doing intersphincteric resections and coloanal anastomosis in any patient above 65. And between 60 and 65, you have to be very careful in selecting your patients. If you need to send the patient pre-operatively to do an EMG and inorectal manometry to assess the sphincter functions before surgery, this is a good way to do it. Otherwise, if you execute the surgery properly, if you work mainly by laparoscopy from above, instead of working transanal and stretching the muscles and putting retractors inside the anus, you will traumatize the sphincters very much. But if you execute the surgery properly, if you work yourself, develop the intersphincteric plane from above, if you do a good splenic flexure mobilization, if you have a redundant colon in the pelvis, the S-shaped colon in the sacral concavity, the dissipation of the contraction wave that we talked about, at the end, functionality will be very, very acceptable to the patient. And the younger the patient, the better the outcome. The younger the patient, the better the outcome. I have patients who are almost, you cannot be 100% normal, but they are almost normal. They will give you, on a questionnaire, they will give you a satisfactory level of 98%, which is better than a permanent colostrum, of course. And because in Egypt, we have another devastating problem, that most of our rectal cancer patients are young.
Yes.
They are very young. We are operating 20s. We are operating 20s. So if
yes,
all of
Professor.
patients, if all of these patients get an abdominal perineal resection, it will be really devastating. So we need to be very selective. And as I said, the younger the patient, the better the outcome.
Okay, sir. Another technical question about the stabling the distal rectum during ultra-low rectal cancers. They're speaking, of course, about the cases you finish them laparoscopically. So they are facing the problem of having single or double stable lines. So how to overcome these problems during, and of course I have some experience by watching you doing the surgery by putting the suprapubic port in some cases and properly placing the port in the right iliac fossa to overcome this problem. But we want to listen to your experience in this problem, sir. Stabling the lower margin.
It is difficult. It is difficult. And sometimes it's very difficult. It depends on the anatomy of the pelvis. The problem is, until now, industry did not help us to get a 90 degrees angulation staple.
Yes.
You need a stapler that goes 90 degrees to be able to transect the rectum properly. But we don't have it, so it does not exist. So it is difficult. Some people, they resort to opening suprapubic incision and putting a contour stapler, for example, or a TA45 articulating of Medtronic to transect, but it will still be very difficult. Stapling in the deep pelvis is difficult.
Yes.
So by experience, I discovered that placing a suprapubic port aligns you better with the direction of the rectum, and it gives you the privilege of transecting the rectum in line with the staple, so you do not need to angulate very much. And instead of firing 3 or 4 staplers to transect the rectum, you will fire 1 or 2. The very, very important thing that most of the people, they omit is the good preparation of the stump. Good preparation of the rectal stump before transection.
Yes.
The better you prepare your stump, the less amount of tissues that you are leaving behind, so that you are narrowing your tube down to the muscle wall of the rectum. Unless you do that, you will always have problems. You will always have problems. So my best advice is that you need to really prepare your stump very, very well. Prepare your stump very well. It is much better to use 45 millimeter cartridges than 60.
Yes.
60 is very big for the pelvis. It is counterintuitive. If you use 60, you will use more staplers, not less. It is longer, but you will use more because you will lose more than 4 centimeters of the stapler line. It will not be applicated on the wall of the rectum. It will be outside. So use of 45 cartridges, preparation of the stump very well. Take your time. Spend 15 minutes more preparing your stump, all the adhesions, all the small fibers, because you get when you go into the pelvis with the stapler, and blade is caught into these adhesions, you will not be able to go all the way through. So it is difficult. It will never be easy. What I'm saying is you are trying to make it easier for yourself. It will never be easy, but these are important issues. You need to have 45 millimeter cartridges. You need to prepare your stump very well. Place a suprapubic port to transect the rectum in line. These are tricks you can use. It will help you a great deal.
Okay, sir. I strongly again recommend attending your surgeries so that you can see those the problem solving during surgery with you, sir. The more you see those surgeries, the more you attend the surgeries, Professor Shokri, the more you get experience. Okay. Another question about the position or the location of the tumor. Does it affect your decision in pre-operative radiotherapy, short or long course? I mean, if the position of the tumor is anteriorly or posteriorly in the rectum, does it affect your decision in neoadjuvant therapy?
No, if the tumor is located anteriorly, posteriorly, or on a lateral wall, it doesn't make any difference. What makes a difference is the location of the lesion to the sphincter. If you have an ulcerating, penetrating lesion that is very low or overlying the external sphincter directly, this patient will do an APR. No matter what you do, it will do an APR. So my choice for radiotherapy would be short course, 5 days and then APR. If you have a patient who has a tumor, no matter circumferentially where it is, but it is 1 centimeter or more above the anorectal angle, you can do an anterior section. So this patient can go for short course radiotherapy. But if you have a patient which is the Eric Roulier type 2 or 3, if you have a lesion really close to the anorectal angle,
yes,
and it is borderline what you can do for the patient, these are the patients that needs downstaging. So these are the patients who need a long course radiotherapy.
Okay, sir. Another question, how you deal, sir, with the anterior resection syndrome post-operative? If I understand well, I mean those problems usually happens with the improper mobilization of the left colon. I think it's more like functional problems.
Low anterior resection syndrome is a very annoying thing. First of all, you must tell your patient preoperatively that he will never be as before surgery ever again.
Yes.
You have to make it very clear, because people sometimes they have expectations that are unrealistic, and the surgeons sometimes they tell the patients things that are unrealistic. So you really need to tell the patient that you will have a very rough period after the surgery for a few months, and then you will be better, but you will never be normal like your baseline before the surgery. This is to start with. The patient needs to have a normal, proper perspective of what to expect. And you should not raise the patient's hopes very high. The second thing is, the problem with the anterior resection syndrome is the inability to evacuate the stool in one motion. This is the main problem. Sometimes the patient does not express himself in a proper way. He will tell you that I have diarrhea. He does not have diarrhea. He does not have diarrhea. He has frequent visits to the toilet, which is very different. He does not have diarrhea, but he's dribbling. He's not making one full motion. He's dribbling. Okay, because the colon is now a reservoir, and there is no emptying mechanism. You lost the brain. The rectum is the brain of the defecation.
Yes.
Okay, you lost the brain of the defecation mechanism. Okay, so what you can do, what I do for all my patients almost, is that sometimes it's on and off. the patient is okay for a couple of days, and then one day he will go to the toilet 15 times to empty the colon. So I tell them, when you develop this, when you feel that you are going to go many times, do an enema. Do a rectal enema. Rectal enema, he will empty the colon all at once.
Yes.
And he will stay for a couple of days in a very proper way. So whenever he has a lot of frequent visits to the toilet, he can perform an enema.
Okay, sir. A lot of questions came asking about the transanal TME. I myself asked a couple of experts about if you can finish the procedure laparoscopically. And you are experienced in transanal surgery. So what do you prefer? So all of them actually answered that if you can complete the procedure laparoscopically, then go on and save the transanal approach for difficult cases. So what do you think, sir?
Yeah. Transanal TME is a very important addition to the armamentarium of the rectal cancer surgeon. It's a very important addition.
Yes.
But I think it has its specific place and specific time. You should not do it routinely by any means. You should not do it routinely, because most of the cases, they can be finished laparoscopically. Most of the cases. But if you doubt, functionally, it is always better to do an anterior resection, a low anterior resection, than an intersphincteric resection. Functionally, low anterior resection is much better than intersphincteric resection. So if you can do for the patient an anterior resection, a low anterior resection, but you are doubting where to cut because you cannot assess properly the distal margin, this is the best indication to use the transanal TME. For me, this is the only indication for transanal TME. If I cannot get a proper distal margin, so instead of doing an intersphincteric resection for a patient who can be having a low anterior resection, you should go for transanal TME.
Of course, sir. So some technical questions about the identification of fascia of Denevrier and the intersphincteric space. And as I told you before, the more you see, the more you get oriented. So how to get more oriented by those fascia and the intersphincteric space, sir?
This is an unanswerable question.
Yes, sir.
How to identify? You need to know. You need to know how to identify. This is something that cannot be talked about. This is something that you have to attend and see many times, so that it becomes a reflex for you. When you see it, it clicks in your mind that this is the anatomical structure that you need to know. This is rectal cancer surgery is difficult. It's a very difficult and a very tough surgery, and it needs a great deal of experience. A great deal of experience. And I insist to say that the patient has only one chance, the first time. So it is not something that you play with. You really, and now it's not like we have started 12, 13 years ago operating rectal cancer laparoscopically and we were on our own. Now there are many centers doing great jobs, great surgeries. So if you want to learn, you must go and join one of these centers, get the experience, get the orientation, get the anatomy, get the help of the expert surgeons who are operating there. This is the way to do it. It is not justifiable nowadays that you should go and try. There is no go and try in rectal cancer. Rectal cancer is treated once, and it should be done properly at the first time.
Okay, sir. For the sake of time, I have two last questions. One for myself, I saved it for the last question, and the one before is the local recurrence after ultra-low rectal cancers. Your experience, Professor.
But these are very miserable cases, and management is very complex. Your best option is to have a central recurrence away from the pelvic wall, and you can get away with re-resection. We did the case a couple of weeks ago or 3 weeks ago. It was a very tough one. Maybe I will upload it on YouTube and the Facebook page later on for everybody to get a view of what we did. Sometimes you can resect, and sometimes you have to do very devastating things. You have to resect the sacrum, do pelvic excenteration. Of course, if you have an isolated recurrence and the patient is excluded to have any form of metastasis at all, it is justifiable to do very major interventions to achieve an R0 resection, even at the expense of other organs. If you do hysterectomy or a cystectomy in order to save the patient's life. But really, these are very tough forms of surgery. The patient has been irradiated, has been previous surgery in the pelvis, and then now he has a recurrence. It's really, it should be done by a very expert surgeon. It should be done in a highly specialized center with all the rehabilitation available for the patient. You can only do what you can do. You can do.
Yes, sir. And as you mentioned, sir, the best chance for the patient is always the first chance.
Yes.
Yeah. Okay. Take home message for all your audience. The optimum plan for decision making for ultra low rectal cancer.
MRI, a proper MRI. A proper
Yes.
MRI is an indispensable tool in the management of low rectal cancer. EUA, a conformal radiotherapy machine, not a regular radiotherapy machine. These are three very important key decision-making tools to have: proper MRI, a good EUA, a 3D conformal radiotherapy machine. If you have these three things and you do them, you will solve a lot of problems. They will make it much easier for you to take a good decision, because you will have a very good idea on the extent of the lesion, on the involvement of the muscles, of the sphincters, of any other organ. And with good neoadjuvant radiotherapy, you will achieve downstaging of a lot of bulky, difficult lesions, and then you will have a better chance of saving the patient instead of doing exenterative surgery. So this is my take-home message. Do things in a very systematized, standardized, repetitive manner. All the cases must have these investigations and preparatory therapy before surgery. If you do this every time, you will find yourself in a totally different area of management of the patient, and you will have a much bigger percentage of satisfied patients instead of having a lot of failures.
Thank you, sir. On behalf of all the audience, your colleagues, trainees, and students, sir, we thank you for this great informative lecture and discussion. And my recommendation is for all the audience, please try to attend the surgeries for Dr. Ahmed, and yeah, you will get very much experience. And he always welcome his.
Most welcome. We have an open door policy at Salam Oncology Center. You can you can attend whenever. And
thank you, sir, for allowing this chance for us.
Thank you very much. Thank you very much.
Thank you, sir.
Thank you. Electronic people, everybody, thank you very much.
Thank you, Dr. Ahmed. Have a great rest of the day. Thank you. Bye-bye.